As clinicians, we're really conscious that patients can often feel unsure and a little bit anxious in advance of specialist appointments. And we often get asked, what's the difference between a regular eye examination and what goes on in a dry eye clinic? So we've arranged tours of 3 different eye clinics, the virtual tours, I'm afraid, of 3 different eye clinics, so you can see for yourself what might happen when you attend for an appointment and give you an insight into some of the innovation happening in the field of dry eye and hopefully combat a little bit of that anxiety. So we're going to start our clinic tours at the prestigious Wellington Eye Clinic in Dublin with Mr. Arthur Cummings. Mr. Cummings is an internationally renowned expert on customised laser treatments, keratoconus and cataract surgery. Now, unfortunately, at the last minute, Mr. Cummings couldn't be with us today, but he sent us a recorded tour so we could still see his clinic and the type of equipment he uses. And he's more than happy for us to pass on any questions that you might have for him. So I think as soon as James is ready, we're going to get the video loaded for you. There we go. So enjoy our tour of the Wellington Eye Clinic.
Hi, my name is Dr. Arthur Cummings and welcome to the Wellington Eye Clinic. So we're a clinic based here in Sanford in Dublin, Ireland, and we specialise mostly in vision correction surgery. So this is laser vision correction and lens implants. But why we have such an interest in dry eye is because of the role that dry eye plays in the quality of vision. So we always like to think that light comes into the eye and bends on the cornea, but the truth is light actually bends on the surface of the tear layer. So if the tear layer is good, you have a higher quality of vision, and if the tear layer is less good, it impacts your vision, and if the tear layer is coming and going and breaking up, you have intermittently good vision. So we're going to share with you our experience of how tears impact quality of vision. We're also going to, with members of the team, take you through the process that people would go through to determine how their tears are impacting their vision and what we can do to try and help. You're going to meet different members of the team, and the first person you're going to meet is Liz, who's going to explain to you how we make appointments at the clinic currently to keep everyone safe.
My name is Liz, and as Mr. Cummings said, I'm the Research and Clinical Support Manager here at the Wellington Eye Clinic. We've made some changes since we came back after COVID, and I'm going to talk you through our patient journey now so you can understand what patients experience when they visit us at the clinic. So the patients at first contact will fill in an online medical history form. This means they can give us all of their details from the comfort of their own home, but also reduce the time that they're spending in clinic when they visit us. It's really advantageous to us as well to be able to prepare for their visit and also to assess exactly what the patient's needs are. When the patients arrive at the clinic, they'll be visiting our sanitisation station, where of course they'll all be wearing a mask, as will all staff, for the duration of the visit. They'll then check in with the receptionist before we take them through and start their tests. So one of the first tests that we always do for every patient is our pre-tests. And these are generally consisting of the autorefraction, tonometry, as well as a full ocular history and a discussion with the nurses or technician team. So they'll go through, that will be the starting point of their journey, and they'll go through then to the optometry team, who will do a refraction, slit lamp exam, again to build on the ocular history and assess the patient's need, as well as looking at the tear breakup time and assessing the ocular surface. We've many devices in the clinic here that can help us further assess the ocular surface, and we'll be talking you through those with Mr. Cummings later on. But once they have had their tests, including any additional tests, they'll then go into Mr. Cummings for their consultation, where they can get their recommendations. So once the patient has finished with their consultation, they come back to the reception area where one of our administration team will look after them, but they actually do also have the option to purchase some of the products that we recommend as well. We found it really beneficial taking stock of the products, as it means that the patient's compliance is maximised when they do leave with the product on the day.
So to really understand how we can help you, you need to understand the anatomy of the eye and the tear layer. So I'm going to share with you this video that we use to explain this to patients.
The primary components of tears, mucin, aqueous, and lipid, combine to create a complex viscoelastic structure. This complex structure is responsible for a multitude of important functions. Lipids prevent evaporation, lubricate, and stabilize the tears. Meibomian glands at the margins of the upper and lower lids produce and inject complex oil into the tears with each blink. This thin layer of oil prevents tears from evaporating and increases lubrication and comfort. Additionally, the phospholipids found in this oil stabilize the tear layer and improve cohesiveness.
So if you blink perfectly every time, you'd never develop dry eye in the course of your life. Because every time you blink and the lids touch, you produce oil. The problem today is, especially with contact lens wear and with working on computer screens, is we don't blink properly. And when we stop blinking properly, the little glands block up and they stop producing oil, and then the tears evaporate very readily. So this is a slit lamp, and it's a microscope that allows us to see the cornea specifically very well as the tear layer, and with special lenses we can see further back into the eye. So Liz has kindly agreed to be a patient, and Liz would sit forward. And why it's called a slit lamp, as you can see that little slit. Perfect, thank you. And that slit allows us to get a cross section of the eye. You've noticed this too, and that's why I could take my mask off now. We've got these devices or screens between all of our examinations, where there's a patient and an examiner on the other side to protect us further.
So now that you understand a little bit more about a consultation and the initial test that we'll do, we'd like to talk you through some of our specific dry eye equipment. So this machine here is a tear lab device, and what this is used to do is to assess the quality of the tear film through looking at the osmolarity. So for the patient, it's a very easy device and very quick test, but for the team, it's really good at helping us to assess the tear film. So what you do is you have a card, you attach it to the device, you'll hear a little beep telling you it's attached correctly, and Mr. Cummins is kindly going to demonstrate, but the tip of the card will just simply sit in at the corner of the patient's eye, collecting a tiny sample of the tear film. It's then funneled in through a little channel, and very cleverly, for a small device, once it appears back on the pen, it analyses it to give a quality score. And once we have that quality score, then we can assess the quality of the tear film. And you can see here, what we're looking for a healthy tear film is a score above 308. So this device here is called the HD Analyzer, and again Mr. Cummins is kindly going to be my patient for the moment, but this device is really helpful in our dry eye clinics because it helps to assess the optical scatter. It uses a double pass system to be able to look at the scatter for the patient, but really importantly to look at the impact of the tear film on the vision. What's really nice from the patient's point of view, and Mr. Cummins will talk you through the interpretation of the scans, is that it's a really easy to understand scan, and it's really helpful for the patients to understand and see improvements in their tear film when they do continue their therapies. So what it'll do is it'll ask the patient to stick their chin in on the rest and their forehead in against the bar. It'll ask them to look just at a little house on top of a hill, taking a couple of scans and measurements, and then finally asking the patient to keep their eyes open for about 10 seconds with no blinking. And much like one of the tests that our optometrists do, that then helps to look and see how long that water layer is staying on the tear film and how long and how quickly it's evaporating from the surface, which of course is really important with dry eye. Another key feature of this device is that it does have a meibography camera. So we can just have a look here. This is one of our staff members who's kindly let us use her scans, but these are images of her glands. So you can see here these lightened areas here are the meibomian glands, which again Mr. Cummins showed you earlier in the video. They're the ones producing the oil and expressing the oily layer out onto the tear film. So this helps us look at the quality of the tear film, because again it's letting us look at the quality of the glands, checking to see that there's no gland die-off, that they're all looking healthy and of normal width, and that they're all active. So again, really important to help us assess the tear film. So this device here is called the eye trace. And while the HD Analyzer looks at the scatter, this device here is a wavefront. So it's an aberrometer, and it looks at the wavefront of the entire eye, but also looks at the wavefront of the cornea. And by doing a simple subtraction, it's able to then separate out the cornea and the internal optics to be able to assess where the patient may be experiencing an issue.
So you've seen the eye trace device and how it works. I'm going to now show you how we interpret the results. So here's a patient who's had an eye trace, and this shows us the quality of how they're seeing the letter E. That's what they're seeing. This is the contribution from the cornea, the front of the eye, including the tear film, and this is the contribution from inside the eye, including the lens. So if you had a cataract, this would impact the number, or if there was a dense floater. So on this particular scan, everything looks very, very good. Let's look at the next scan, and on this scan, things are more blurred. So the surface is quite blurred now, and it's also slightly blurred internally, but it would be because of this. So we've seen a change on the front surface. We now look at the next scan. This is showing that things are very clear again. So the moment we see a variation on the cornea, the only thing that can cause a variation on the cornea is the tear film, if it's coming and going. So with a good blink, there's a nice optical surface and you get a good image, and at a time of a poor blink, you get a bad image. So this is confirming for us that this person is dry, that is symptomatic in terms of the vision. So you've seen the HD analyzer, this machine that works on the double pass scatter, and it's measuring scatter. So I'm going to show you how we interpret the results. So the first thing the device looks at, this is this patient's right eye. This is the image being projected into the eye. This is what's actually landing there, and the ocular scatter index is very, very good at 0.7, and it's in the green range. When you start getting into the yellow range, it's an early cataract, and in the red range, it's a dense cataract. But now, that's the overall optical scatter. If we now look at during a 10-second blink cycle, we'll see that part of the image for one part was very sharp, but other parts started degrading. So this was the best image while it's in green, but then other parts started degrading. If you look at the other eye, you see that the overall ocular scatter again is very, very good. There's very minimal degradation of the image. But if you look at the tear film now, you'll see that the tear film also had episodes of very, very good and other parts that weren't quite as good. When we showed you the slit lamp exam earlier, we do a test called the tear breakup time, but that's an invasive test. It's a test where we put dye in the eye and we see how long it takes for the dye to break up. In this particular test, it's doing it without the dye, so it's non-invasive, it's a non-touch test. So in this particular case, the tear film is only lasting for 3.5 seconds before it breaks up and starts impacting the vision. And the quality change goes from this, where you're seeing this bullseye, to it starts smearing. So I want to show you first of all how we do something called a warm compress. Warm compress is putting heat on the eye, it softens the oil, it dilates the little glands. But then we need to express the oil. So this is
little
one of the
circles at the back represent the meibomian glands, and these little lines in front represent the eyelashes. So this is the eyelid margin with the lashes in front and the glands at the back. And what we're doing with the meibomian gland expression is using a Q-tip to exert pressure directly onto the gland for about 5 seconds, trying to express the oil, and then going to the adjacent spot for about 5 seconds. And
you may have heard people say just use your finger, but the thing is, pressure equals force over area. So your finger has such a big area that you can't push hard enough to increase the pressure to release the oil. So when you use a Q-tip like this with a small area, you get a good pressure. And then on your own eye, it looks like this.
Q-tip, and it's applying the pressure perpendicularly. The Q-tip goes just below the eyelid margin, and you're expressing oil by squeezing the lid between the Q-tip and the eyeball, and then you go to the adjacent spot and do that for about 5 seconds.
And it takes you about 12 goes to get from the one corner to the other, so about a minute per eyelid. Now, you could land up doing this and find when you come back for your visit that we say there's been no improvement. And the main reason then is in fact that despite the fact that you have glands, that you've softened the oil by means of the compressors and the heat, you're still not releasing oil. So these little glands can actually physically be blocked. And that's when we do something called meibomian gland probing. We have a small little device that we do in our theatre that can physically open each little gland. Sometimes these glands are covered by skin or biofilm, and until those little glands are opened, you can't release the oils. It's also important to note that the very first time you do this, success may make your eyes feel slightly worse. So if you start releasing oil that's been stuck in your glands for a long time, that oil's quite inflamed and it can be, gritty and chunky. So we tell people the first few days you might think you're going backwards, but the moment you start feeling your eyes are gritty once you've started the treatment, it's an indication that you're achieving success and you're releasing oils.
Hi, I'm Sophie. I'm one of the nurses here at the clinic, and I'm going to show you the 2 treatments we use for dry eye as well. The first one is the MeiboFlow, which is this little device here. It heats up, and we place gel on the lower lid, on the upper lid, and we massage for about 10 minutes on each eye, like this. And it basically heats up the oil in the glands and helps it express out if you're having trouble with that. After we do that treatment, we get the cotton bud and we express again as well. And usually it's about 3 to 4 treatments depending. The other option is the IPL, which uses light pulses to stimulate the nerve glands. So it's about 5 buzzes on each eye, with about 2 centimetres of gel on each side.
So thank you for joining us on our tour of the Wellington Clinic. I know it was virtual, but we hope you've learned something from this.
Okay, I think we lost a tiny little bit of the sound at the end there, but I hope it didn't spoil your enjoyment. I found that really interesting to see around the clinic of Mr. Cummings. So if you have any questions for him, pop them in the Q&A and we'll definitely email them off to him for him to answer for you. So now I'd like to introduce you to Professor James Wolfson. Now James is Associate Pro-Vice Chancellor at Aston University in Birmingham in the UK. He's an expert in dry eye and the tear film, and he's going to take us on a tour around the university clinic, and we're going to explore some of the latest equipment that they're using there in order to manage dry eye.
Hello, my name is Professor James Wolfson. Welcome to Aston University, which is in the centre of the UK, in Birmingham, which is the UK's seventh city. So you can see here our campus, which is right in the city centre. So what I'm going to do now is walk you through the short distance from the centre of the campus to our dry eye treatment. So if you'd like to follow me. So we're now coming up to the Vision Sciences building. This is the largest optometry training centre in the UK, with about 150 students in each year of the course, including postgraduates as well. And just opposite the way there, you can see our refractive surgery and surgical centre, so 2 large operating theatres where we do cataract and refractive surgery. Our clinic has about 5,500 patients a year who come in for a variety of clinics, everything from primary care through to specialist clinics in myopia control, paediatrics and of course dry eye. So let me show you through to the clinic. So I now introduce you to some of our dry eye facilities within the clinic.
Worse than I was last time when I came here. The pain is like almost constant,
Right.
From the start of the day till the end. Like it's not very like that I can't cope with it, but it's like I can feel these eyes all the time, like different kind of pain, like stabbing pain, or like a, like a sand under the eyelid or something like that.
And what drops and things are you using at the moment?
I was using these that you gave me, but not really, not improvements, no changes. No.
And are you using anything else like the warm masks?
Yes, that's I continue that, so twice a day, morning and before I go to bed, like 20 minutes. I've got this electric mask that I use, which is really good, like USB mask. Massage after the warm compress. And, most of the day I use like an eye wash, just like saline solution that helps. So it's the same like eye drops, so I don't really use the eye drops that much.
Okay, fair enough. So we're going to do the third of your intense pulse light therapies today. Obviously you have a bit of an improvement after the first one, but not so much after this one. But normally we would do sort of 4 of those over a 2-month period. So we'll take a quick look at your eyes, see how they're doing. I can see that the symptoms have got a bit worse. So let's have a look at what that's happening on the ocular surface. So healthy tear volume as you had before. Just check the stability of the tears. And blink once more, that's good. And dry open if you can. That's excellent. Doing really well there. That's good. Here we can see that the tears are still quite unstable and breaking up. And again, just looking straight ahead, we'll just have a look at the oily layer on the front of the eye now. And blink for me there. And blink again. Blink once more. That's good. Just going to do the redness of the eyes. Again, nice and wide open for me. That's great. Just go across the other eye this time. Now blink. Again, we'll have a look at the stability of the tears. Blink for me. Blink once more. That's great. I'll dry open for me. Doing really well there. That's great. That's it, just blink that through there. Again. Once more. That's fine. And then finally, eye wide open again for me. That's great. If you like to sit back and put some eye. That's great. Great. Okay, have a blink for me. Moving into the other eye. And then a blink for me. Keep the eye nice and wide open if you can. That's good. Back to the ceiling for me. Just let any oils come out of those glands. Just looking straight ahead for me there. Previous time, I'll just count down for each of the flushes. So 3, 2, 1. 3, 2, 1. 3, 2, 1. Second. Yeah.
Is that different than last time?
No, this is the same as last time. Yeah. So sit back and relax. And we'll let it go. There we go. So this will last about 15 minutes. And you'll just slowly feel the skin heat naturally. And hopefully it's quite relaxing experience.
Thank you so much for joining us. Dry Eye Clinic, Aston University, UK, Birmingham. Thank you.
Thank you.
Bye.
Bye.
So that was an amazing tour looking at some new technology and technologies that we might actually have experienced ourselves looking around the dry eye clinic at the university. I think Professor Wilson is going to join me shortly to take any questions or explain anything there. But it was interesting to see that both him and Arthur Cummings have IPL in their clinics. Oh, James, lovely.
Hello.
Thank you for that amazing tour. The university department looks, you know, some fantastic equipment there. Have you got anything that you wanted to add to what you did on the video? Do you do all those tests on every patient that comes through?
Yes, so what we wanted to show you a little bit different to the Wellington clinic was these are the standard approach. That was actually a follow-up visit. So we were interested in assessing how things have changed over time. The patient there, who very kindly allowed us to film her consultation, has been through a couple of IPLs already. So what we were doing in that visit was assessing the tear film and the quality of the ocular surface before we then did a further treatment. And after 4 treatments, then we would do more therapeutic expression. So this is when we use what essentially looks like some small tweezers, where we can put a little bit more pressure on the glands to get that flow going up. But I guess the big difference with our clinic is it's much more devoted to science. We've all seen a lot of discussion about science during COVID, and it's really important with dry eye that we examine the treatments. There are so many treatments out there available, many directly to the patients, some through the clinics, but we want to know which ones work best, when they work best, so at different severities of the disease, or whether it's more evaporative or aqueous driven, and also in terms of how it's going to work for that individual person. So coming to our clinics, they're open to the general public, but we also often get people if they fit the criteria involved in different studies where we can do the latest treatments. So for example, we're using amniotic membranes at the moment under a contact lens to enhance the ocular surface of people with more moderate to severe dry eye. We have studies following patients through for 5 years to see how their meibomian glands change. We're looking at some of the latest equipment and how robust that is. We're doing some work on some new advanced scleral lenses that can actually bathe the ocular surface consistently, but have a very nice smooth coating on them and very high oxygen transmission. All of things which point to better comfort and better quality of life for dry eye patients, but the science hasn't yet shown that to be the case. So I'm on the executive for the Tear Film and Ocular Surface Society, which is the international society that looks after dry eye. And our focus always is making sure that we go with that global consensus and learn through the science. So you saw the IPL there, but you also saw intrinsic heat, which is a NASA technology to actually heat the glands from the inside. So the LEDs feel cold to the touch, but you get that warming through the glands. And then we have lots of equipment we didn't show you to image the corneal nerves with confocal, tear sampling, liquid thickness analysis, etc.
Perfect. Actually, you answered one of the questions there that was a comment in the chat saying it was interesting that the heat was added after the IPL, you know, the red lights we saw there on the mask. In the interest of time, can I stop there and invite you back? We're going to look around one more clinic and then I'll have you and Nick and we can ask some questions generally about the different areas because there's been a little bit of overlap. You've all got sort of variations, but what's been so useful, I think, is that nothing in there is really scary. Everything else is really useful and it just prepares us to know what we're going to come up against when we come through the doors into those clinics. So I think what we're going to do now is we're going to have a look at our final tour, and Nick Rumney is going to open the doors to his award-winning practice, BBR Optometry in Hereford here in the UK, where he runs a really successful and high-tech dry eye clinic. Nick's an honorary professor of clinical optometry and a prescribing optometrist, which actually allows him to successfully manage some of the more severe cases of dry eye in his own practice. I'm delighted to see your face there, Nick, because you're going to talk over your video and explain things as you go along for us, aren't you? That's
the plan. Let's just hope this works.
It will work. It will be fab, Nick, with every faith in you.
Okay, so you're going to see some things that you will have seen before. So you could probably start the video there because people will recognize that Tear Lab setup. The key thing about that is, along with some form of ocular surface disease index questionnaire, the numerical values that you get from the Tear Lab are pretty much the only numerical values that you're going to have to find out if you're subjectively improving things. So that's Jemima, who's one of our IP optometrists, is doing the Tear Lab. You can see we're waiting there for it to register. It's like a lab in a chip, really. It's a little gold probe, and it comes up with a number. The higher the number, the higher the salt content of the tears. Now here, Jemima is looking at an alternative method of tear film analysis, similar to what James and Arthur have shown you. This device is called the LipiView. It's probably one of the first generations, and it's probably heading towards obsolescence. It was quite an expensive device at its time. And that's Emily, one of our dispensing opticians, just demonstrating. Now you can see there how it forms a video autofocus image of the tear layer and of the surface of the eye. And that band of white that's lower in the eye, that band of white is the actual reflection of the tear film. And so what we're seeing is a series of flickering patterns that generate the color fringes that you might see on an oil film on a puddle. If there's a little bit of a rainy day and an oil film on the puddle, you see that rainbow fringing, and that tells you the thickness of the tear film and the thickness particularly of the oil layer of the tear film. So there's a certain amount of analysis involved with this, so we'll just wait for the computer to work that one through. And the important thing is that we start with the least touching type of test. So the Lippy view here would be one of the first ones to do, probably followed by the tear lab. Because the more you do things with somebody, the more you're getting them to look at things, the more you're potentially touching the eye, the more the results become variable. So we need to try and make sure people attend without makeup, without their contact lenses. Now, if we just stop that video there for a second, if somebody can do that, what you can see there are a series of blinks over a 25-second period. So each time there's a little picture of an eye on the top part of that graph. That's where there was a blink. And it will record whether those blinks are complete or whether those blinks are partial. And one of the key things we find is that a proportion of people actually have partial blinks. The two lids don't quite meet, and that can be quite a problem. And what you can see on the left-hand side on the x-axis is the actual thickness in microns of the oil layer of the tear film, and that's showing quite an even number of blinks within that 25-second period and quite an even thickness of oil layer. Okay, you can replay that now. To the right-hand side are a series of colored bars on to the side of the eye, and that color fringing tells you the thickness in microns of the oil layer of the tear film. You can actually see it within that band of, almost like looking into a window, and that tells us a little bit about that. So in a moment, that's going to move on. We've got to the end of that video. And there's the colored fringing band. And the next thing is a different form, a different way of looking at the meibomian glands themselves. And this is very similar to one of the instruments that Dr. Cummings was showing. Basically, it's use the same device, but we have to just modify the position of the headrest. You'll see that it just pops in and pops out. Okay, so what Jemima is going to be holding now is a little probe that will rest against the eye. It's an infrared light source. And that's the little device sitting there on the cable. She's pointing the camera so that it goes to the correct part of the eye. And you can see that's just applied under the folded lid. So as you draw the lid down, we're now looking at those oil glands under infrared, and you can see it's a slightly pixelated image with higher contrast than a conventional black and white image. And that enables us to actually look at the oil glands. One of the challenges when you're trying to manage meibomian gland dysfunction is if it's been there for a long time, some of the glands might actually be disappeared. And you can see them as dark bars there, some longer than others, some seem to be joined together. So again, most of these are they're all absolutely painless, simple tests that can be done that just give us that little bit more information. And here are the infrared pictures that are shown on the screen. And there is a computer analysis algorithm in there that can score for us the likely outcome. It's also possible to do the upper lid. Now we move on to the more invasive procedure. So you've seen a slit lamp previously with Dr. Cummings. This is applying one of the colored stains, and the one we most typically use is sodium fluorescein. We use the smallest amount possible, and the reason for that is that fluorescein itself acts as a solvent for the oil layer of the tears, and the intention of that is to show us whether there is any disturbance in the tear film. And so here is a pattern. When you see that blink, it's really like water on a Teflon frying pan. If you've waxed the car and it rains, then the water won't run over the car, it beads. And that's why you get these dry patches. That's why on the blink it becomes uncomfortable. And that's why when we're looking at screens and things, if you have got meibomian gland dysfunction, you don't blink quite as much. And then when you do blink, it's more uncomfortable. Again, going back to the 20-20-20 rule, you can see those dark patches there are showing where there is poor wettability on the surface. And so you'd get interesting different types of drops will be aimed to look into that. Now, this is Laura, one of our dry eye specialists, and Matthew demonstrating this is one of our clinical assistants. Now, we are all in the same bubble, and so that's why Matthew's not wearing a mask at the moment. Laura is. And you'll see also why he's not wearing a mask, because once again, we're going to be applying a gel so that we can actually undertake the IPL treatment. Once again, you've seen IPL both in Arthur Cummings' lab and also with James. What Laura's doing here, which is quite interesting, is you have to cover over any minor pigmented skin blemishes simply because you get increased heat absorption through infrared if you've got a couple of little moles or little blemishes on the skin. It's important that this is done without makeup. Matthew's obviously without makeup today. And it's also important that you dial in the correct dosage, because different levels of skin pigmentation require different levels of infrared dosage. Laura's about to apply the gel. And there are essentially two different forms of IPL available. One is this type which we're using called the EI, which requires a gel to act as an interface between the IPL unit and the skin. The other type is the type that James used, which doesn't use a gel, but then uses an activating heat mask afterwards. And I think it is more a matter of personal choice. Laura is programming the intensity of the laser scan. And these devices have a finite life to them, so the actual laser head gets replaced periodically, and that's a component of the cost. It's not just the chair time, there is a consumable cost with running this system. The laser's in that head. Now, because I'm videoing this, I'm able to shut my eyes, and you'll see the flash coming up. She's also guarding the beard growth so that doesn't get flashed. Typically, there would be 5 flashes across the lower lid. Now, you can either, as the operator, either wear goggles or glasses that are not going to absorb the laser, or you can close your eyes at the moment of pressing the button. We tend to call it a laser. I think really it is an IR, an infrared flash. We call it a laser because that acquires the necessary level of seriousness that it is a unit that you have to be cautious using. Laura's just cleaning off the marks around the edges there. So this is a procedure we've been running at the practice now for 3 to 4 years or so. What we're doing next is using a sister device to the Pt.5 made by the same people, Tier Science, and this is the Pt.5 Flow. So this is the device that is going to actually mechanically remove the meibomian gland oils. Laura's applying a minor drop of anesthetic to the eye, a little bit of a sting, and this is probably the more invasive procedure, but again, it's well tolerated for the 10 to 15 minutes that it takes to complete. So Laura has a device here that actually looks like a rather large grey contact lens. The original devices for these attach directly into the unit. These actually attach to a cable that remains attached to the unit, which has significantly reduced the cost. But this is a once only consumable item, so the cost is partly in the chair time. The cost is also within the unit, which has to be discarded after patient use. So that clicks into there. And the white part that you can see there goes against the surface of the eye but forms a bridge so that it doesn't actually contact the seeing part of the eye. It's applied onto the eye, and then the lids are popped in between the grey and the white. We secure that with a tape, and that's going to remain in situ for the 20 minutes of the process. So we'd fit one to the right eye, one to the left eye. It's very comfortable. There's no pain involved. And what that will do now is go through a heating and compression cycle on both eyes over a period of 20 minutes or so. And it plots that out on the graph. So you can see here those little staircase ramps on that right-hand side. And that shows it's going through the heating process. The square block is where it goes through the compression process. It is quite close to the eye, but perfectly safe. And we found our best results have come from patients where we've used both IPL and the LipiFlow as a combined procedure. So you'd have the LipiFlow, you'd have the first IPL, and then you'd have 2 more treatments of IPL. It seems to be something that helps to completely clear out the glands, and then you have to be very judicious in the use of lubricating drops immediately after for the next couple of weeks, because it takes a little bit of time for those glands to refill. But where you have impacted glands and they are open enough, but you can't really squeeze enough of the material out using the methods that Arthur has shown you, then this is the way to empty it. As far as I'm aware, there are about 10 to 12 LipiFlow units across the UK in different places. And that's pretty much the video that we wanted to show you. So I'm sure there will be some questions for James and I. We wanted to emphasize the fact that these things are not unpleasant or painful. And they're quite accessible within an office that is not it's not a kind of hospital type procedure, if you like.
Yeah, thank you so much to you, Nick, and to James for showing us an insight into your clinics. I think it does really help to see what might go on, to know of the different treatments and techniques that are actually available as well, so that we can ask the questions of our own clinicians to see whether it might be something appropriate for us. There's a couple of questions coming on the chat. Nick, I think this is relating to LipiFlow. Is this expression process possible to be done on patients who have a history of corneal erosions?
As long as the cornea has a high degree of integrity and is not currently affected by an erosion, then I don't see that there would be a contraindication there. But if you've got active corneal disease, if you've got something like an epithelial basement membrane dystrophy that's visible, and certainly if you've got active meibomitis or a chalazion, then that is contraindicated. You have to medically clear the surface of the eye first. Okay.
But great results with it, you know, positive results, feedback from patients.
Yes, I think the interesting thing was it's a bit of a curate's egg when we started, because cost-wise, it's one of the more expensive procedures out there. And when we first introduced it, it was recommended and seemed to be sort of industry standard to be over £1,000 for doing the 2 eyes. A lot of that was due to the cost of the consumables, which have come down considerably. And we've reduced our prices to make it more attractive. The key thing about something that is of that nature and at that high level of pricing when it first came out was that it tended to be used much more on people who had really, really struggled and had really, really severe aspects of meibomian gland dysfunction. And so by the time you're getting to see them, many things have been tried. It's been a problem there for them for many years. And they actually have not all that many meibomian glands left that are adequately functioning. And I think the biggest lesson that we've learned is that it is really, really useful to get in and do these treatments whilst you've still got a full complement of meibomian glands, albeit they may be a little bit blocked or a little bit impacted. But if you leave it too late, you're only working with maybe a third of the normal gland level, and you're really struggling to get good results with that. And that's the real challenge, because anybody and everybody who has suffered from meibomian gland dysfunction knows that the symptoms aren't really that apparent in the early stages. It's as you get further into the condition that it becomes more and more challenging. And of course, these things don't come alone. If you've got meibomian gland dysfunction and you've got an evaporative dry eye, the probability is there'll be an aqueous component to it as well. So I think with these things, sometimes the earlier the better.
Yeah, absolutely. I agree with you there. Thanks, Nick. I've got a question for James now. You mentioned scleral lenses that provide hydration to the eye surface when you're talking about your research. How does this differ from current scleral lenses, and how far along is the development of this type of scleral lens? There's a wee bit more. What's the goal of the study related to current scleral lenses users with a damaged corneal surface? And thank you very much for your tour. They found it very interesting.
Okay, so scleral lenses have been used for a long time to protect the ocular surface, particularly in ocular surface disease. And there's quite a lot of evidence around their use in dry eye. Not totally convincing, but a reasonable amount of evidence. What's new is the development of coatings that go on the lenses that make them very slippy. And while that is important, is basically it increases their comfort, because the lids, for example, glide over the top rather than there being friction. And there's a very recent paper showing that this coating, which is nanoparticles thick, dramatically increases the comfort of these lenses, making them more applicable in dry eye. Where we're going a step further is there's some research from our group looking at new lenses of different oxygen permeability, so the amount of oxygen that passes through them. And that quite surprisingly showed that some of the new ultra permeable lenses actually increase comfort. Now, that wasn't specifically in a dry eye group. So what we're having a look at is that combination of this slippy surface and this really high oxygen permeability going to make these lenses comfortable enough to be a really good solution for dry eye, because we know that the hydration that they hold against the ocular surface is good, but what we don't want then is friction between the lid and the lens itself.
But that would be an amazing breakthrough, wouldn't it, if we could find something like that? So great.
Yeah. And certainly when we've tried them on patients, we get a very good reaction from sclerals usually. So if we can get that sort of long-term comfortable wear, that would be a real bonus.
Yeah, thank you. Nick, a question for you. It came through in the chat. Has anybody used EvoTears, and would the panel recommend them? Now, I do have inside information to know that you use EvoTears, which is why I've picked on you for this one. Any of the panel are quite welcome to answer too, but your thoughts?
So we received some of the very early trials in part of the seeding process from Scope during the lockdown, and one of the most interesting aspects of it was, you know, as a practitioner, you often like to use things yourself, and people might notice that I actually have a prosthetic right eye, so I'm, you know, in the world of the blind, the one-eyed man is king. But that prosthetic dry eye does get really quite dry, and conventional lubricants don't really work for it. And so that was an opportunity to try the shield, and it worked extremely well. It's very, very slippery, and it's almost the only product that I've really come across that's particularly helpful for people who need, if you like, an enhanced lipid response. So many of the other products, they do stabilize the tear film and add moisture and prevent evaporation, but this one really seemed to work in that particular category of patients. And every time we've restocked our shelves, they've sold out very quickly, and we've restocked again. So yes, I do recommend using that in that particular group of patients.
Thanks, Nick. That's lovely to hear. I feel I do exactly the same, but it's good coming from somebody who's totally independent.